Bismillahirrahmanirrahim. Assalamu alaikum. Good morning, and I hope all of you are safe at home and you are following our program of online. We are going to start about the breast and the breast diseases. We know breast is very important. It's a very sensitive topic, important for your examination point of view, important for your clinical point of view, important for because it's very sensitive topic and very sensitive issue to be discussed, and particularly in our society where most of the time we are concerned with conservative societies and the people. So this topic should be very much clear to most of the students, whether you're going to be surgeon or not, whether you're going to be a breast surgeon or not. You should have a basic core knowledge. And today we're going to talk about the anatomy and physiology of the breast, and we will have some brief overview of the diseases of the breast. First of all, anatomy and physiology of the breast, introduction and general information. Embryologically belongs to the integument, from the skin surrounding the string, and functionally a part of reproductive system. Breast is situated in the subcutaneous tissue in the pectoral region, and modified apocrine sweat gland, and apex of the cell becomes part of secretion and breaks off. It's present in both gender, males and females, but when we will be talking about the diseases of the breast without any additional qualification, it is to be taken as adult female breast. Anatomy, the position and the attachment. So, lateral aspect of the pectoral region. Lateral aspect of the pectoral region, located between the 3 and 6, between the ribs 3 to 6 or sometimes 7, extend from the sternum to the axilla, and surrounded by superficial fascia and rest on deep fascia of the pectoral region. So just have an overview of the anatomy of the breast. You can see the ribs, the intercostal muscles, and the pectoralis muscle. Then you have a you can see the breast parts different. Can be seen the deep fascia of the pectoralis region and the prepectoral space, and you're going to have a suspensory ligament of the breast which runs from the deep fascia to the skin, and they are called suspensory ligament of the breast, or the Cooper's ligament. Then you can have the lobules containing alveoli, secondary tubules, mammary ducts, lactiferous ducts, nipple, areola. This is the sagittal section, and coming towards the anterior view of and you can see the lobules. Position and attachment of the breast: fixed to the skin and underlying fascia by fibrous connective tissue bands, but a Cooper's ligament or suspensory ligament, and ligament may retract when the breast tumors are present, and it invades, and it results in the dimpling of the skin and fixation of the structure. So these are suspensory ligament or fibroelastic component of the breast, and suspensory ligament of the breast, the Cooper's ligament, another same picture. So these are the suspensory. Left breast is usually slightly larger. There's no worry and no panic when the patient presents with the left breast is larger than the one. Base is circular, either flattened or concave, separated from the pectoralis major muscle by fascia or retromammary space, in which runs a lot of lymphatics. So when we do the section for mastectomy, so this is the space where we work mostly. Retromammary space, as shown in this picture, the retromammary space. Again the ligaments. Intercostal muscles, ribs, pectoralis muscles, and retromammary space, the breast tissue. You can see the Cooper's ligament, alveolar glands, and different set of ducts, lactiferous ducts, ampulla and alveolar ducts, which converge over the ampulla and lactiferous ducts, and they open up at the level of nipple. Structure of the breast: the outer surface is concave, convex, so skin covered. There is a nipple at the fourth intercostal space, small conical or cylindrical prominence below the center. So the way nipple is located, fourth intercostal space. And as I mentioned, the set of ducts from the alveolar region, they converge over the ampulla, and then the lactiferous duct merges, and they are all the lactiferous ducts opens into the nipple. Nipple is surrounded by areola, which is a pigmented ring of skin, thin skin region lacking hair and sweat gland, and contain only areolar glands. Areola contains dark pigment that intensify during pregnancy and lactation, circular and radial smooth muscle fibers, and causes nipple erection at the time of lactation. Areola. So this, in the right picture, in the anterior view, you can see the pigmented area around the nipple is called areola. Each breast consists of 20 lobes, approximately 20 lobes of the striated tissue. Each lobe has one lactiferous duct. Lobes and the ducts arranged radially and embedded in the connective tissue and adipose tissues of the superficial fascia. Lobes composed of lobules, and lobule comprises of alveoli. So this is the structural unit of the breast: lobules, lobes, and the lobules. Again, the same picture showing so you can see the lobes containing alveoli, secretory ducts, mammary ducts, lactiferous ducts, and nipple. This is the secretory unit of the breast. Excretory or lactiferous duct converge towards the areola. From the ampulla collection sites of the lactiferous sinuses, ducts become contracted at the base of the nipple. Excretory or lactiferous ducts. So two pictures, two views, A and B. Alveolar glands, alveolar ducts, ampulla, lactiferous ducts. Other view in frontal cross sections. Secretory epithelium changes with hormonal signals. Onset of menstruation, pregnancy, gland begins to enlarge at the second month. After birth, first secretion is called colostrum, contain abundant antibodies. Tail of Spence or axillary tail. It is worth mention because the axillary tail is sometimes mistaken as axillary mass or lymph node mass, or sometimes an abnormal mass. So it's just a prolongation of the upper outer quadrant in axillary direction, passes under the axillary fascia, may be mistaken for the lymph nodes. Axillary tail. Okay. Tail of Spence. Fatty tissue surrounds the surface, fills the spaces between the lobes. So this fatty tissue or adipose tissue determines the forms and the shape of the breast, and it fills the spaces between the lobes and lobules, and it surrounds the surfaces. No fatty deposits under the nipple and areola only, and the rest of the breast contain large amount of fatty tissue. Breast and the fatty tissue. Alveolar glands. Adipose tissues can be clearly seen. So, nerve supply, blood supply of the breast. Arteries derived from the thoracic branches from the three pair of arteries, axillary arteries. Continues with the subclavian. Give rise to external mammary or lateral thoracic artery. Internal mammary arteries, first descending branch of subclavian. Supply intercostal spaces, breast, used for coronary bypass surgery sometimes. Intercostal arteries, numerous branches from the intercostal, internal and external mammary arteries, supply intercostal spaces in the breast. So that's all the arterial supply to the breast. Subclavian, axillary, external mammary and internal mammary. This is a set of sources of blood supply to the breast. Subclavian artery, axillary artery, external mammary or thoracic artery, and internal mammary or internal thoracic artery. Vessels and veins. Veins from the ring around the, this is important, from the ring around the base of the nipple called circulus venosus. Large vein passes from the circulus venosus to the circumference of the mammary gland, and then to the external mammary vein, to the axillary vein, or internal mammary vein to the subclavian vein. So, two main drainage sites. External will go into the axillary and internal mammary will go into the subclavian vein. So, again, the venous system, from the circulus venosus around the venous nipple, veins passes from the circulus venosus to the circumference of the mammary gland, and then to the either to the external mammary or internal mammary. Both will drain as axillary and subclavian vein. So this picture will explain the venous drainage of the breast. You see the circular venosus around the nipple, and then venous network going in both external and internal mammary vessels to the subclavian and internal and axillary vein. Innervation derived from the anterior lateral cutaneous nerves of the thorax and spinal segment T3 to T6. This is very important, lymphatic drainage, because the most important disease involved the breast is breast cancer, and the breast cancer it metastasized to the lymph nodes, very important route of spread, and the lymphatic drainage. So most important knowledge for the surgeon and the clinician, the medical student, is lymphatic drainage of the breast. It's very important university question and comes in your paper 1. Important university question: what is the lymphatic drainage of the breast? And sometimes it comes like, name the different axillary lymph nodes or draw the lymphatic drainage of the breast. So it's important. Lymphatics, clinically significant. It's important for your examination point of view. So clinically significant, glandular lymphatics drain in anterior axillary nodes or pectoral nodes, central axillary nodes, apical nodes, and deep cervical nodes, and subclavicular subclavian nodes. Medial quadrants drain into the parasternal nodes. So look at this picture. So nodes from the medial side go to the parasternal nodes. Nodes on the lateral side will go into subclavian, axillary, and lateral pectoral nodes. Basically 4 set. And out of these, it is the axillary lymph nodes which are clinically palpable, accessible. So there's an important part in the T&M staging of the breast cancers. So that's why, so whenever we examine the breast, we need to examine the axillary lymph nodes. Superficial region of the skin, areola, nipples, from large channels and drain into the pectoral nodes. Axillary nodes also drain lymph from the arms as well. So just focus on the axillary lymph nodes. Majority of the lymphatic drainage goes to the axillary lymph nodes. As we know, though, when you talk about the 4 quadrants of the breast, there are 5 parts of the breast. For clinical point of view, the 5 part, the 1 nipple areola complex, and the 4 quadrants. And quadrants name are upper outer quadrant, upper inner quadrant, lower outer quadrant, and lower inner quadrant. 70% of the tumor arises from the upper outer quadrant because it contains most of the glandular tissue, and it has its extension in the axillary tail, and that's why the lymphatic drainage is more towards the axillary area. So that's important. So this is the detail of the axillary lymph nodes, lateral lymph nodes, central lymph nodes, subscapular lymph nodes. You can name them as anterior, posterior, lateral, but subscapular lymph nodes, pectoral major muscle has been shown, and the parasternal lymph nodes on the medial side, and pectoral nodes on the lateral side. Mammary glands shown in this picture. So we can have apical nodes, we can have central nodes, we can have anterior pectoral nodes, we have posterior, anterior, posterior, central, apical. So the 5 group of axillary lymph nodes, they are important. Routes of metastasis: from medial lymphatics to the parasternal nodes, then to the mediastinal nodes. Across the sternum in lymphatics, opposite side via cross mammary pathways, then to the contralateral breast. From the subdiaphragmatic lymphatics to the nodes in the abdomen. then to the liver, ovaries and the peritoneum. Major routes of metastasis: axillary lymph channels, subdiaphragmatic lymph channels, channels to the contralateral breast. And similarly, we have other routes of spread metastasis like blood-borne spread to the lungs, to the brain, to the skin, and to the other parts. Then direct spread from the skin to the deeper muscle to the chest wall. So certain congenital anomalies of the breast: inverted nipple, congenital are due to the cancer. Ectopic nipples mean they are not at the normal site. Sometimes you have polythelia or hyperthelia, sometimes additional nipple along the milk line, amasia or micromasia. These are the congenital anomalies. Diseases of the breast: most are readily detectable. Etiology is unknown. Influencing factor may be the gender, hereditary factors, endocrine influence, menstruation, tenderness from the fluid engorgement, postmenopausal, pregnancy. So, briefly, what are the common diseases of the breast? Common diseases can be categorized into two groups: benign diseases and the malignant diseases. Then benign diseases can be further divided into inflammatory diseases and neoplastic disease. So commonly there may be like mastitis, like breast abscess, like benign diseases can be in the form of nipple retraction, in the form of there may be fibroadenoma, fibrocystic disease of the breast. So they are the benign diseases. Out of the malignancy is a carcinoma of the breast, is the adenocarcinoma, and it's a two type: lobular and tubular and ductal carcinoma of the breast. So general symptoms and the signs of the breast diseases: the nipple discharge is always significant if the patient is not lactating or pregnant, maybe due to the benign pituitary tumor or benign diseases like lactocele, like mastitis, sometime periductal mastitis, nipple retraction, there may be greenish discharge. So nipple discharge is significant and it can be purulent in the form of pyogenic liver abscess or mastitis. It is when it is blood-stained discharge in duct papilloma, sometime malignancy. Similarly, when the discharge is in the form of greenish discharge, is ductectasia or periductal mastitis. Similarly, when it is purulent, it is serosanguous, it can be either ductectasia or it can be simple infection. Local pain or tender, either cyclical mastalgia or in the form of mastitis. Duration of lesion is important. Chronic lesion may be in the form of benign disease, and progressive lesion denotes the size and the rate of the growth is important. Retraction signs are dimpling or involving of the skin or nipple areola, or you can Paget, what you call is Paget disease of the nipple, and sometimes there may be a pudiorange involvement of the skin, subcutaneous lymphatics. Mobility of the mass is important. So this is very important once the mass is mobile or not. Mobile mass, movable is likely benign. and not invasive, like breast mouse, we call it fibroadenoma of the breast. Malignants are attached and they may grow, they invade, and they are fixed most of the time, either fixed to the breast tissue or fixed to the pectoralis muscle or fixed to the chest wall. Again, as you know, the consistency of the mass is important. Cysts are fluctuant, compressible, fibroadenoma are rubbery and mobile, carcinoma are firm, hard, and may be fixed. Axillary lymph nodes can be and very notable important disease. Carcinoma most of the time present with painless lump in the breast. They may be Asian male. Session. Tumor and the cyst. Tumor and the cyst, they are fibroadenoma or benign. Most common benign breast tumor is also called the breast mouse. Is well circumscribed, well defined, and highly mobile. Breast cysts are often found in the breast, and they may be aspirated if they are large, and they can be confirmed by ultrasonography. Carcinoma of the breast, most common malignant tumor among almost highly sensitive to the different hormones. And one point I want to make it very much clear to you people: breast is the organ which is highly dynamic organ and changes with the different manipulation of the hormones. So that's why the clinician must be very aware. There's no predefined consistency of the breast in a particular individual. So you need to examine the normal side first before you palpate the involved site or disease site, so that you should have an idea of normal consistency of that particular individual at particular time, because the consistency of the breast changes with the different cycle of different phases of the menstrual cycle, as it's more dense, more engorged, tender in the premenstrual period, and then it's changeable in the different phases of the reproductive life of the female, as in the early menarche, in the first half of the reproductive cycle, breast is firm, granular, dense, and in the later half is involutory breast and is more lax. So this is important, should be kept in mind to the clinician. Then the breast is highly affected by the pregnancy and lactation. So this organ remains in changes and influenced by the different hormones, estrogen, progesterone, prolactin, and other hormones during the different reproductive phases, as the different phases of menstruation, different phases of pregnancy, after the pregnancy is over, the lactation, and so the different hormones the female use for the contraceptive pills all affect the breast. So they all should be kept in mind. And when you take history of the breast problems, always ask about the any hormone replacement therapy and all of these things. So the breast is important organ, it's important part, so that we spend full lecture on orientation and anatomy, physiology, and orientation. Next time we will talking about the benign breast diseases. Carcinoma is important. Carcinoma is very important. But we should not miss the benign diseases. They may not kill the patient, but they may cripple the patient a lot. As like breast pain or mastalgia and fibrocystic diseases. So we will be talking about the benign breast disease. And ladies and gentlemen, the classic name and classification for the benign breast is called ND. ND stands for aberration in normal development and involution. ND, ANDI. ND stands for aberration of normal development and involution in the breast. So aberration in normal development. As you know, what is the normal sequence of events? So breast develops in the first half of the reproductive cycle and involute in the next half of the reproductive cycle time. So it's anything which is abnormal or aberration in the normal development and involution of the breast is called ND. So all are the grouped under the. So we'll talk about the benign breast diseases, of the infectious diseases, inflammatory diseases. We'll talk about the breast pain, or the mastalgia, cyclical mastalgia, non-cyclical mastalgia. We're talking about fibrocystic disease. We'll talk about certain benign tumor of the breast. So next lecture we will be talking about the benign breast diseases. Thank you very much, and your attendance will be after the assignment. Thanks.